So now, after we have moved forward from the monovision and the presbyopic LASIK, which is the micro monovision with the extended depth of focus, both of which were actually corneal approaches, I'm going to take to you about another corneal approach I'm very fond of, but of course there are very, very few patients who are actually satisfied the selection criteria for this. This is the corneal inlays. This is one of my area of interest. And my mentor, Professor Ioannis Palikaris, is the reason that I have got interested in this corneal inlays, which is designed by him. I have been a former research grant recipient with this particular inlay design, which is Flexivue, when I was doing my fellowship with Professor Ioannis Palikaris. As we all understand, as the baby boomer generation is aging, there is an increase in demand for presbyopia correction. Refractive surgeons of today, as you have seen, they are adapting to various new methods of presbyopia reversal, and continuous research and innovation is getting translated into novel development of novel techniques. So this is a very busy slide. You may not be able to read all of it as well. But what is one statement I would like to make for it is that basically when you have any particular entity for which we are finding a solution, and when we are looking at so many solutions on the same slide, that means that none of the solution actually works very well for every single patient. So we have to really customize our approach for presbyopia. It's extremely important, and what we follow in this regard is Professor Ioannis Palikaris' presbyopia algorithm, in which we actually choose patients according to their age and their refractive error and choose the best possible procedure for them. For example, anyone who is younger in presbyopia, so we basically choose an approach which is corneal, especially monovision or corneal inlay or the presbyopic LASIK. Anyone who is beyond 55, even though they may have a clear lens, is a strict no for us to do anything on the cornea, because sooner or later they will have either aberrations at the lenticular level or they will have cataracts. So for them, I definitely prefer to do a clear lens extraction and then probably replace it with multifocal lenses or newer designs of extended depth of focus lens such as Symphony. But however, I think there is one area which is really tricky to treat, which is between 45 to 55 age group, and especially if these people have a pre-existing refractive error. As we understand, basically the million-dollar question is today in the presbyopia industry is how to manage a plano presbyopic patient who does not have any error for distance but has only presbyopia, and he's between the age group between 45 to 55, so doesn't find a sweet spot there. So basically these people may be too old for corneal lasers such as myopic monovision, and may be too young to do something as invasive as lenticular approach of lenticular lens exchange. So we need a method for this target group which will be minimal invasive, and most importantly, if the patients are not happy, it has to be completely reversible. I think that is something that is very, very crucial. Corneal inlays actually kind of satisfies that need. Corneal inlays are intracorneal lenses. They work on various mechanisms similar to inducing smart monovision. They improve the uncorrected visual acuity for near by modifying the monovision approach itself, and they are implanted in the mid-stroma of only one eye, which is the non-dominant eye. So now we have already looked at how to actually identify the dominance of the ocular dominance from Dr. Praveen's presentation. So where are we going to put this inlay? Is going to be only non-dominant eye. There are three inlays which are currently basically under scrutiny, and they have been widely used, some of them in the United States, such as AccuFocus or camera inlay, for which you must have heard about it. There is another one which is Flexivue inlay, which is our area of interest, and there is Revision or Raindrop, which is the third inlay, which is also getting very popular. What I'm going to talk to you about is going to be about the Flexivue inlay. Flexivue inlay is actually like a thin contact lens. It's made up of acrylic material. It's only 20 microns in its thickness, and it's 3 millimeter in its diameter. So it's basically a bifocal inlay. It is shaped as a donut, as you can see very well. It has an outer portion in which you have a near addition. It can range between 1.25 to +3, and it has a central portion which is absolutely refractively neutral, so which is supposed to give rise to a good distance vision in that operated eye as well. So when we actually took one of these patients and did what is called as an eye tracy wavefront analysis. What is eye tracy? Eye tracy is a wavefront analyzer which can look at a total ocular wavefront and can actually separate the corneal wavefront from the intraocular wavefront as well. So when we are looking at the total ocular wavefront after this, the inlay has been in place, you can see that in the periphery of the inlay of this donut, you can see there is a bit of myopic wavefront. All right, and in the center, as you can see, it looks as a emmetropic wavefront. So this is what exactly is this inlay trying to do. So how does this inlay work optically? So basically the inlay works on the principle of smart monovision. Alright, what is a smart monovision? It is a pupil dependent monovision. As we all understand, when we are actually seeing for far, the pupil has a certain diameter, and when we look for near, the pupil becomes meiosed, and basically it is the diameter of the pupil actually goes down. So the bottom line of this point is that whenever we are looking at far, the rays, because this inlay is only 3 millimeter in diameter and the pupil might be much larger, as we know the ambient mesopic pupil is about 5.5 to 6 millimeters. So the rays are actually going from distance from the periphery of the inlay and as well as the center of inlay. They are getting focused onto the retina very well, and the rays which are actually going from the myopic part of the inlay are actually getting focused much before the retina itself. So basically there is no blur which is actually done by that, and you have a relatively good distance vision. What happens when you go for near? Basically when you go for near, the pupil comes back to almost 3.5 millimeters of diameter, so in which most of the diverging rays which are coming from the near are actually going to hit the part which is myopic in the periphery, and the other rays will go through in the center. So the rays which are actually going to be focused are going to be from the myopic part as well, giving us rise to a better vision for near. So when we have actually done a dynamic wavefront in this regard, we have seen that whenever this patient looks for near, his wavefront goes myopic as much as 2.5 diopters. So this patient have a dynamic range of near vision in which you can actually see this dynamic myopia has gone to almost 2.5, give rise to very, very good near vision. So when again the patient looks for far, he has a good distance vision. So how are they implanted? Initially when the AccuFocus came in, because AccuFocus was probably the first inlay which was designed, it used to be implanted under the LASIK flap, as you can see. So but there are certain problems with this approach, because the LASIK, under the LASIK flap, if you put this inlays, they can easily move because of the manipulation. The other thing is that the location of the inlay ideally has to be seen optically best at about 280 microns of corneal depth. So whenever we put it under the LASIK flap, as you of course understand, which are very superficial, they are usually 100 to 120 micron flap, so the position of inlay is much anterior. So after that there was a new approach which was tried to design, in which there is a complete flap cut, but there is no side cut, and there is only one very small side cut at this 12 o'clock angle. And now as you can see, from this small side cut the inlay is being implanted, but again you cannot go at much of a depth, and there is a lot of room for the inlay to move about. So basically Professor Palikaris came up with the idea that we should create a pocket for this inlay and do not put it in the flap, and this is actually the microkeratome which was designed in-house by our team. You can see that this looks very crude, but this is how the initial pockets were made, and actually the inlay was implanted after that. After that we actually started to work on a software to create a pocket with the help of the femtosecond laser itself. Now you can see, instead of the microkeratome, with the femtosecond laser, it has become very simple and elegant to create the same flap. You have a better predictability of the flap depth as well as the diameter and the dimensions of the pocket as well. There is no flap now, there is only a pocket. So basically once you have gone in with the separator and given a nice irrigation, this is the implantation system of this Flexivue inlay. Flexivue inlay is a completely transparent inlay, so you have to be very careful when you implant it. It's very thin, again 20 microns in thickness, so you should make sure that it doesn't fold onto itself. Once you have done that, basically then you go inside. The patient is actually on the eczema laser right now and looking at the fixation light. So how do you center this inlays? You have to center this inlay onto the first Purkinje reflex when the patient is looking at the fixation light of the eczema laser, or any other fixation light for that matter. You can see there is this green light on the wavelight eczema microscope that we have been utilizing. This is the slit lamp examination, which shows that this inlay even on the first day is completely invisible as against the AccuFocus, and basically centered very well. So this is a part of the small trial that we had done on 31 plano presbyopic patients, which were enrolled with the mean age of 47 years and age ranging between 45 to 52 with a minimum follow of 6 months. You can see that after the inlay was implanted, the efficacy of improving the uncorrected near vision in this inlays was excellent, where more than 80% of them improved their uncorrected near visual acuity by ETDRS chart, by the near ETDRS chart to about 20-25, which shows excellent efficacy for near visual acuity without any glasses in the operated eye. It took